Well, welcome everybody to the public board meeting of the NHS. I have apologies for absence from Julian Kelly, and Matt Style is stepping in for him. Does anyone have any declarations of interest that they would like to mention? No. Is everyone happy with the minutes of the last board meeting, which we held on the 25th of June? Okay, thank you very much. So, Simon, I'm handing over to you for your Chief Executive's report.
Thanks very much, David. The board's put in this extra meeting because we knew that at this time we would be pivoting between dealing with the ongoing coronavirus response and the restart of other services across the NHS, as well as ensuring that work was underway to prepare for extra demands that might be placed on the NHS in the event of a second spike and going into the winter period. So the main business before us this morning is to take track of the work that has been done on those fronts. We are coming down, obviously continuing to come down from the peak of inpatient emergency coronavirus pressures, 933 COVID positive inpatients across the English NHS hospitals as we speak. And so, as we discussed at our last public board meeting a month ago, by the end of this week, July 31st, we will make a determination as to whether or not it's appropriate to step down from the level 4 EPRR national incident, while nevertheless standing ready to re-escalate should circumstances require. And we will capture that in the so-called phase 3 letter that we will be sending to the NHS following the discussion we have at the board this afternoon to finalise what that should look like. And as part of that, Amanda and I and colleagues have been meeting virtually with our colleagues across 7 regions in the NHS, from trusts and from CCGs, integrated care systems, and also with a number of the national patients groups representing the public and patients in areas such as mental health, cancer, older people services, to make sure that their perspectives are built into what we're doing. We also expect that within the next several days, we will be publishing the long heralded 2020-21 version of the NHS People Plan. I particularly want to thank Perena and colleagues for their work on that. And looking ahead to our public meetings in October, 1st of October, that's when we will also be bringing forward a NHS England and Improvement response to the very important report that Baroness Cumberledge published a few weeks ago, and which the Department of Health and Social Care are coordinating the cross-sectoral response to in the meantime. I do also just want to say that, as well as dealing with those immediate here and now questions for the balance of the year, the debate on coronavirus and what needs to be learned has also served as a focusing moment for some of the bigger discussions that have got to be got right. So on social care, we are, I think, beginning to see increasing urgency around the need to provide proper support for the social care sector, which is obviously something the NHS supports in its own right, and it's strongly reliant on getting right, looking out over the autumn and winter. On obesity, this past weekend and into early this week, good progress being made on some of the wider measures that have been in debate for at least 5 years. And as part of that, an enhanced NHS response, including widening the diabetes prevention programme and other ways in which the NHS will play our role. And finally, on inequalities and the way in which coronavirus has multiplied and exploited those and their impact on health, considering particularly around race and health, I want to use this opportunity this afternoon just to announce that, as discussed, we have made an appointment now to chair, the inaugural chair of the Race and Health Observatory that is being hosted by the NHS Confederation. Following open advert, that post will now be held by Marie Gabriel, very experienced NHS and public service leader. Similarly, Perena Issar has appointed to our own equality and diversity and inclusion team, Jenny Douglas Todd and Mike Franklin, also following public advertisement, experienced leaders from outside of the NHS per se, and they're complementing the work that Owen Williams, the Chief Executive of Calderdale and Huddersfield NHS Trust, is leading with Ian Dodge and colleagues on building in the race lens into the health inequalities work that we are committed to advancing this year and beyond. And finally, we are this afternoon publishing the 2019 version of the arm's length body workforce race equality standards measures, as well as a new set of proposals for measuring race inequality in the medical profession, the medical res. So I think everything else, David, will be covered later in our agenda, but that perhaps sets up the discussion for this afternoon.
Good, thank you very much, Simon. Did anyone on the board want to have any questions of Simon before we move on to the sort of operating performance of the NHS? Okay, let's move straight on then to Amanda and Matt Stile, who are going to present the operational performance report. Amanda.
Thank you, David. So if I just give the headlines, hand over to Matt to talk about the financial performance, and then, of course, welcome any questions. And indeed, I know that Pauline Phillip is with us and more than happy to talk about some of the detail if that's helpful. So just to say, clearly, we're aware that we've had a completely kind of extraordinary experience over the last few months. And I think, again, just going out and about over the last few weeks, beginning to reconnect with people on the front line, just struck again by what an extraordinary response it really has been across the whole of the NHS. That's true. It's true of primary care as it is of mental health specialised services across the board. But what we did see, and I know we've talked about this before, of course, was a significant drop off in the sort of usual demand for services in that early period of the COVID peak. But we're now beginning to see services absolutely start to move back to or towards pre-COVID levels of activity, and indeed demand beginning to move in that direction as well. So just to be specific for a moment, as you know, we saw a drop-off in A&E attendances and emergency admissions at the beginning of the COVID surge. Predominantly, those were patients with minor conditions, but we are now seeing an upturn, an increase in demand at the front door for urgent emergency care. Performance against a 4-hour standard continues to be very strong, linked, of course, to a much reduced level of demand. 111, and we'll talk about that later, continues to be very busy and has been a critical part of our ability to support patients through the COVID response. And I think really, again, one of the many areas where actually we've been able to innovate to respond at pace and in a way that has been very complementary to the rest of the service offer over this period. Moving on to referral to treatment, elective care. So what we've got at the moment is, of course, a declining number of people actually on the waiting list, but we are seeing an increase in the time that patients are waiting. And that, of course, is connected with the reduction in routine activity that was performed over the last period. So we are now at a much higher number of patients waiting more than 18 weeks, waiting indeed more than 52 weeks than I think anybody would be comfortable with. So the big focus, of course, for the NHS, and we'll talk about that more in this meeting, as we really lean into the recovery, not just of our urgent services, but actually increasingly now of our routine services, is to make sure that we have achieved that kind of restoration of elective care to deal with both the urgent and the longer waiting patients. We've been really encouraged by the fact that more people are now coming forward for cancer care. So that's Help Us to Help You campaign. Just really want to encourage continue to encourage anyone who has concerns that they might have symptoms that could be indicative of cancer to seek help, because the NHS remains completely open for business where we need to be, and in particular for patients on cancer pathways. I think we've talked about it before, but we have developed hubs for cancer surgery now. All 21 cancer alliances have them up and running, and they have enabled us to maintain a high level of cancer treatment through the whole of the COVID period. I won't say any more specifically about elective care, although obviously happy to talk more about it if that's helpful. We are seeing, I think, worth saying on primary care, the data is slightly less straightforward to interpret on primary care, and we know it doesn't give us quite as accurate a picture. But again, what we are seeing is an increase in demand for GP appointments, both face-to-face and online or by telephone. And again, I think it's been an enormous shift away from face-to-face to digital ways of providing care that we've seen in primary care has been echoed in mental health and community and in secondary care, which has allowed us to continue to operate at a high level of activity despite some of the COVID restrictions, and really keen to continue to encourage the use of those digital routes. Although, of course, as Simon said a moment ago, one of the things we are very keen to do is make sure that we're really looking at that through an equalities lens to make sure that it's not excluding anybody from accessing services when they need it, but actually is a genuinely additional service for those who for whom it is a good option. Final couple of things to say. Mental health, we have maintained the commitment to both the investment in mental health and continued the absolute commitment to achieving the same outcomes in mental health services throughout the COVID period. And what we've seen is a huge amount of adaptation in service provision. Again, enormous innovation across mental health. But we are aware, I think, and have been throughout, that there was likely to be an increase in demand, both from the population and indeed from support for our own staff for mental health support on the back of what they've experienced these last few months. And we are beginning to see a definite increase in demand for mental health services as anticipated. So a huge amount done to maintain services, but definitely beginning to see demand coming through. Final thing I just wanted to say was really to just draw the board's attention to the 4th annual leader report, which was published by the University of Bristol on the 16th of July. And that is, we've published our leader learning from action report at the same time. And that's a really important piece of work because it brings together a lot of the learning around people with a learning disability and or autism. There's some quite challenging findings, and we, I think, feel absolutely a sense of continued commitment and the importance of not losing sight of what is a very ambitious work plan around this area. So absolutely maintaining that focus on the care, education and treatment reviews, absolutely maintaining a focus on the leader reviews, and continuing, of course, to support people to move away from inpatient settings where that's appropriate. So those where that's possible and appropriate, and indeed, of course, the challenge to us is to make sure it can be. But just that. Well, in fact, you know, that's probably enough, isn't it? Let me hand over to Matt, and then we can take questions if helpful.
Thank you, Amanda. Matt?
Thank you, Chair. So as colleagues are aware, we have since April been operating a simplified financial framework across the NHS, effectively comprising block contract values to cover the sort of pre-COVID cost base, plus retrospective top-ups to ensure that the resources were available in a timely fashion to allow the NHS to respond to the pandemic. The paper presents the financial position at month 2 in the context of that revised financial framework. On a year-to-date basis at month 2, we have incurred additional COVID-related costs of around £3 billion, broadly speaking, split 50-50 between providers and commissioners. that includes in the provider sector lost income, so principally lost income from private patients, commercial income, local authority income, and research income. It includes additional pay costs and additional non-pay costs, drugs and clinical supplies being probably the largest elements within that. After offsetting savings, the overall year-to-date overspend has been £2.6 billion. These figures do not take account of some costs which are being borne separately and nationally by the Department of Health and Social Care. As it's presented, as I've just presented it, and as it's set out in the paper, as I say, we're showing an overspend, but just to be clear with the board, arrangements are in place to ensure that those costs are met and funded by the Exchequer, and the expenditure is in line with the arrangements we've made with the government to cover this the costs of COVID over the course of this year. And I think I'll leave it there.
Thanks very much, Matt. Any questions for Amanda and Matt?
David, can I come in as well?
Yeah, do well. Yeah.
So Amanda, thank you very much for your update on how the services are responding and recalibrating. Is there more we can do though to get the demand side really moving on, so that actually the underlying waiting list starts to reflect a true reflection of what's going on? I mean, there's mention of the fact that nosocomial infection rates has gone crashing down. And I just don't think this is in the public mindset. Is there more we can do there?
Thank you all. I think that's I think this is an incredibly important point, because one of the things that we're really conscious of is that that referral rates have not bounced back to anything like pre-COVID levels. So there is, I think, a genuine risk that what we've got a line of sight to those patients who are in the system. We don't have a line of sight to those people who've not yet presented. So clearly we do have campaigns like the Help Us to Help You campaign. We're working closely with colleagues in PHE, DHSC and others around the kind of public information. But I think one of the big learning points, certainly from the, for example, the outbreak in Leicester, or the increasing prevalence of COVID in Leicester, is actually how important getting those messages out to local communities from trusted local leaders is. And so it's not to say that there isn't an important role to play for national campaigns. I think there is, and we need to keep doing that. But I think we need to really complement that with CCG-led, local authority-led, local NHS-led messaging, including direct contact, of course, between clinicians and their patients, that encourages people who are in the system already to feel confident they can come and have their appointments and come into hospitals, but also to make sure that we're really talking to local communities to give them confidence to seek help if they need it.
Thank you.
Thank you. Any other questions for Matt or Amanda? Well, Amanda, can we go straight on to the next item, which is yours as well, please?
Thank you, David. So this, I referred to this a moment ago, but the next paper is about our approach to recovery. So we have sent, myself and Simon, 2 letters in the past. One was really asking the NHS to prepare for the first wave of COVID. The second was talking about the importance of restoration of critical services. The next kind of communication that we've been developing, I should say, very closely in conjunction with both colleagues across NHS England and NHS Improvement, but also with quite deep engagement with colleagues across the NHS and support from other colleagues in government and more widely, has been our sort of phase 3 communication, which is really about the next stage of our recovery. So what we're intending to do is get something out potentially even this week if we can, which gives people a sense of the priorities going forward. So at the moment, what we're describing is a number of key priorities. If I just say very quickly what they are. So building on what I've just said, absolutely this focus now on recovering as much elective activity as possible. So that's not just the urgent work, it's the routine activity as well, getting back as near as possible to pre-COVID levels of activity. That's across outpatients, diagnostics, day case inpatient care, recognising that it's not straightforward because we have to do that in a way that's safe for our patients, safe for our staff, but also recognising the reality, which is, thankfully, levels of COVID are currently low. And therefore, we do have a window now, certainly, where we can prioritise getting back to normal as much as possible. And we need to do that in order to make sure that we're delivering the care our patients need. So that's a big priority in the letter. Also talking about, and again, it links back to something Simon said in his introduction, but the importance of health inequalities being at the heart of our approach to recovery. So encouraging people to continue to work in systems, to continue to work with partners, and make sure that we're really thinking about how we provide care to a population rather than just thinking about a sort of organisational level approach. Other headlines, you'd expect me to say this, but restoring primary care and community services, because that is the bedrock from which so much else in our service is built. Really good news that we've got continued funding from the government for care for the first 6 weeks following discharge. So that's an important component of the community offer. We're talking about mental health services in the letter, in line with what I've just said about what we now expect to see and are seeing in terms of that growth in demand for mental health services. And of course, we continue to talk about the importance of learning disabilities, autism services specifically within the letter. Other things we're talking about, again, you'd expect me to say this, but it is about our cancer care and making sure in that that we are prioritising access for patients who are on cancer pathways. Final thing that we're really trying to kind of call out in the letter is the look forward to winter. So what does that mean? Well, very specifically, it means an unprecedented scale of flu vaccination campaign. So that is both for the population, but of course also for our own people. And that's going to be an important feature of our preparations for winter, continuing, of course, also to make sure we're well set up to respond to any local outbreaks should they arise, and that we're continuing absolutely to have that appropriate focus on infection control, which includes things like staff testing and the ability to make sure that we're able to respond should there be a second wave more generally as well. Final thing, I think probably for me to say is, and it links to, again, some of the other conversation we've had, is that we're really wanting also to encourage colleagues across the NHS where we have been able to make beneficial changes in this first wave response to COVID. So where we've been able to do things like use 111 to help direct people to urgent care services that aren't a front door physical presentation at A&E, where we are able to use digital alternatives to face-to-face care, really trying to make sure that in our letter we encourage people to continue to do that and really lock in that way of working to become something that's much more routine in future.
Amanda, thank you very much for that. You couldn't just elaborate a little bit on the diagnostic hubs, could you? I'm slightly, I'm not quite sure what they mean and how far you've got with it.
Diagnostic. So the thing that I was referring to earlier was the cancer hubs. So that's been the cancer alliances that have organised hubs in each of the 21 alliances to make sure, really through the first wave of the pandemic, but they've continued on with this, that they had sort of, if you like, COVID minimal, COVID safe way of continuing to provide, in particular, surgical treatment for cancer patients. Often that meant using the independent sector, of course, because they were able to do that as a way of protecting cancer pathways from routine access through other hospitals. For diagnostic hubs, that is very much part of the long-term plan commitment, actually, around where we were going with diagnostics, and it recognises, I think, the work that Mike Richards has led on looking at where there is an under-provision of access for diagnostics and a desire, of course, to invest in improving that. What we're doing at the moment is trying to use a number of different approaches. One is this process that we've called Adapt and Adopt, to bring a really creative, clinically led kind of approach to thinking about how we restore services and how we expand services, and diagnostics has been very much kind of part of that. And one of the things that they have done is come up with ideas such as using the Nightingales, where they are physically set up to do this well, to provide diagnostic services while they're not needed for coronavirus care. So the Exeter Nightingale and the Harrogate Nightingale, or the Northeastern Yorkshire Nightingale, which is based in Harrogate, both of them are currently operating effectively as diagnostic hubs. And it's that sort of creative approach that we're encouraging in the short term. But it is absolutely part of the long-term investment and the long-term strategic direction for community diagnostics.
Okay, good. Well, thank you very much, Amanda. I'm sorry, this is quite a quick sort of run through. As you know, this was a board meeting that was put in. Oh, David Roberts, you've got a question.
Thank you, Amanda. One of the things that we've been bedeviled with over a number of years is the variation in outcomes and quality and cost that we see across different parts of the health system. Given the need for improved productivity across the piece, to what extent are we able to use this as an opportunity to try and reduce variation and share learnings and best practice from across the country to be able to improve outcomes for patients and productivity, and therefore for more patients, not just for those who we've been able to serve?
Thank you, David. So I think you're absolutely right to pick this out as again one of those areas where I think there is, it's been such a hard experience, hasn't it, the last few months for COVID, but looking for those opportunities and those things that we have done well that we can build on and do more of. I would say one of the very obvious things has been around the strength of clinical leadership through this first few months, and what we are doing at the moment with the leadership of Tim Briggs, who leads the GIRFT programme, Get It Right First Time, and the regions, in particular London, who are kind of pioneering this work, is saying, well, as we restore services, let's use the clinical leadership and the expertise that sits in our existing GIRFT programme and apply that across the whole of the approach to restoration. So they've been very targeted in which areas. They've started with orthopaedics in particular and ophthalmology, but will intend to spread not just now out across the rest of the country, but also, of course, to a wider number of services as they begin to plan and implement that restoration activity. So absolutely, David. And I think this is a real opportunity for us to fast track something that, again, we would want to do anyway, but really using our kind of clinical colleagues and clinical leaders to help drive that.
Thank you, Amanda. Ruth?
Thank you very much, Chair. So in support of all of what Amanda's done, none of this can be achieved unless we've got our people that can support the delivery of this. So from a nursing point of view, I'm delighted that we've got over 12,000 more registered nurses now in providers than we did have this time last year. Our vacancy rates has gone down from 43,000 to 36,000. But there's still more to do, and that's why I'm committed in supporting Amanda and Julia's work and the board's work on this, that we really focus on three buckets of work to support the need to achieve more registered nurses very shortly. Our domestic supply, I'm really pleased to see the 20% increase of UCAS applications and the work that we're doing jointly across HEE and ourselves to attract more people to want to be a nurse. And of course, the retention work, retaining our people that Perena and Emma leading is fantastic. And of course, then the work, the international recruitment, obviously being slightly delayed given that travel restrictions have been placed during COVID. But we have now at least started to see some of those come through. We had 23 nurses come from India week before last that's going off to Sheffield. So we're starting to see some of that work, and I'm sure Duncan and myself will continue to work on that. So collectively, we support the deliverability of what Amanda has just been talking about.
Good. Thank you very much, Ruth. Good. Well, thank you very much for that, Amanda. That's really helpful and informative. So the next item is around the future of urgent and emergency care services, and I think Steve and Pauline, you're going to lead this discussion.
Yes, thank you, Chair. And in fact, I'm going to immediately hand over to Pauline, who leads this work. Pauline.
Thanks, Steve. So the paper that you have in front of you essentially covers two areas. As far as urgent and emergency care is concerned. Some of it addresses the preparation that we're doing for winter, and importantly, it also focuses on the next phase of transformation. And I think board members will be very much aware that over recent years, from a UEC perspective, we've been driving ahead with this transformation agenda. At the heart of the agenda is an ambition to ensure that if people need urgent care, that they can receive it locally and receive it in the best possible place. But if they are seriously ill, if they're in life-threatening situations, that they will get to the right place, have the right level of expertise in the right time. Clearly, that ambition is very much enabled by the development of new models of care, technology, etc. The last couple of months have obviously been a very interesting and somewhat challenging period from an urgent care perspective. But we have also seen some significant changes. We've seen changes from a patient point of view, i.e. how our patients want to access services and their expectations of how those services should be delivered. We've also seen service changes, in some ways being fast-tracked, changes that we had been planning over a period of time and suddenly being delivered overnight. So what we've set out in this paper are sort of 5 pillars moving forward. I'm not going to talk to each of them in detail, but just highlight a couple. I think the first one is building capacity for this winter and beyond that. An investment of 450 million, which we will be announcing in detail over the coming days. And the purpose of that money is to ensure that our urgent and emergency care services, our departments, the front of our hospitals are safe from a nosocomial point of view, but also to enable some of the transformation that will take place now and in the immediate future. The second area that the paper addresses is focusing on 111 services. I think in Amanda's earlier report to you and in previous reports to the board, we've talked a lot about the 111 service and what it successfully delivered during the COVID period. And we see even now that we have more calls, we've got more people going online, and it's a service that our population has very much valued. And what we want to do is to be able to further develop that service and to really talk about 111 first, so that we can encourage people that if they feel they have an urgent or emergency care need, that they go online to 111 or they pick up the phone and contact 111 before they do anything else. And that by so doing, that they will get a better offer and that it will be easier for them to be directed to the service that best meets their needs. Clearly, in order to do that, a lot of work is taking place behind the scenes. We're increasing the clinical advisory service behind 111. We're increasing the amount of call handlers, increasing, really importantly, the directory of services that 111 can access, so that they have very real places to direct people when they present. For the first time, introducing direct booking into our emergency departments. So if it is felt that the best thing to meet your need is to actually go to an emergency department instead of having to go along and queue up, you can be given a booked appointment, etc. So you will be able to have a better experience of arriving and being seen almost straight away. And importantly, communicating all of these changes. So that's the sort of the second area, and it has to be supported by the development of new pathways, by technology, etc. We've got a number of early movers, one really in each region, that is trying out this different way of delivering 111, or this enhanced way of delivering 111, and all of the feedback that we are getting from those first movers is really positive. In fact, I think right across the NHS, people want to move ahead with this as quickly as possible, and certainly in advance of the winter period. Just to mention the critical role that 999 will also play as far as this is concerned. And going back again to Amanda's report, I just want to draw out the fact that for the second month in a row, our 999 services have been able to meet all 6 standards. And I think it's fair to say that the ambulance service has gone from strength to strength in the last 6 months. But really importantly, they've continued the transformation agenda and having more see and treat, hear and treat types of services. So it's not always conveyancing to hospital. Clearly, over the course of the coming weeks and months, what we're really doing is sort of introducing something like a different social norm, that people traditionally have accessed emergency care by turning up in an emergency department. And now we're saying there are better ways of doing this, and having a comms campaign that will really enable people to use the service most effectively. Just a couple of other quick things and then I will stop. In order for our urgent and emergency care services to deliver successfully in the winter period, we, as always, are very much aware of the need to ensure that our hospital capacity is there. And this year, it's probably a bigger challenge than in previous years from an infection control point of view, etc. So making sure that we've got the right number of beds and continuing the transformation work that we have been doing around length of stay, working with our external partners around discharge. And we have seen some excellent results in the last couple of months, etc., around how we can really try and ensure that when it's right for a patient to leave hospital, that they're able to return to their home and to their place of residence as soon as possible, and being able to continue to do that. And finally, the last thing that I just wanted to mention, and I'm going to really hand back to Steve, is how all of this connects in with the review we've been doing about how we measure the performance of our services and our clinical services review. So I'll hand back to Steve.
Thanks, Pauline. So I think the last important thing to say is obviously how we measure performance is really critical too. And as the board is aware, we've been undertaking at the request of the former Prime Minister a review of the clinical standards that we use throughout the NHS, including in urgent and emergency care. That work had progressed last year with pilots in 14 sites across the country who were helping us develop a set of metrics that we initially proposed just over a year ago, but we have worked on with those pilot sites. Prior to COVID, we were working very closely with patient groups, with important stakeholders such as the Royal Colleges, to develop those initial set of metrics with the input from the pilot sites into an advanced set of measures. And I know we had agreed on a bundle of metrics that we felt was very pertinent to the way we wanted to reform urgent and emergency care. Our view is that COVID has cemented the view that we collectively had before the pandemic, that these were the right metrics and that they are important metrics to look at going forward. And so we are now in a position that we hope to publish a report soon, and are of course in discussion with colleagues in the Department of Health and elsewhere in government as to that report.
Good. Thank you very much, Steve. Any questions for Pauline or Steve? This is quite a profound change, isn't it, Steve? You know, this could make a huge difference to sort of A&E performance and the treatment of people.
So I think what's important, as Pauline's highlighted, is that this is a series of changes. This is a transformational project of which measurement is one part, but actually the key parts are doing things differently in the way that we ensure that our processes to access emergency care ensure that patients are treated in the right place at the right time, and that's fundamentally what this is about.
Good. Thank you very much. And Pauline, thank you very much for all the work you've done on this as well. Steve, the next item is clinical innovations during the last sort of 3 or 4 months, and that's you, Steve. And is Kathy joining the call as well, or not?
No, Kathy's on annual leave, so it's just me. So thank you, Chair. So I think we have touched on this subject a number of times in the last few items, because both Amanda and Pauline have highlighted some of the innovations and change that has been required during the pandemic. And a lot of that, as I think Amanda highlighted, is work that we already wanted to do as part of the long-term plan, but in fact we've had to accelerate and go harder and faster as a result of the pandemic. And I think the first thing I'd say is, I think, as Simon has said previously, this has really shown how agile and flexible the NHS can be when it is absolutely required to be. Of course, of those many innovations, we want to identify and embed those innovations that we believe will improve patient care. And this paper really sets out for the board how we are going about identifying those innovations and ensuring that we capture them and we can embed them where appropriate. I'm not going to repeat the paper, but it does highlight some of the key innovations, and you've heard of some of those already. We've just talked about changes to 111 and the emergency care pathway. Amanda highlighted how we have digitized and remote consultations a lot faster. So one statistic for you is that in January 2020, earlier this year, I think 30% of practices were covered by the deployment of remote online consultation and video consultation, and by June that was 90% of general practices. So a rapid expansion over a very short period of time. And of course, although it's entirely appropriate for patients still to be seen face to face where that's important, we and general practice want to hold on to the advances that we have made there. And the other example I would give you is on clinical trials, because this is an international example, and the NHS has managed to put a huge number, more than 130,000 patients, into the recovery trials, which I think have shown how you can rapidly develop and roll out trial protocols during an emergency, a health emergency, and rapidly get clinical results that now being peer-reviewed, published, and are no doubt changing the course of the management of the pandemic and saving lives, not just in the UK, but throughout the world. So we set about capturing those innovations led by the Improvement Directorate under Hugh McCarthy. We called for submissions from frontline clinicians and professionals to capture all the innovations that have occurred. We've had over 1,000 responses, and we are now in the process of analysing those, led by Hugh's Directorate. And as I said at the start, working out what we need to hold on to, what we need to embed, and how we do that going forward.
Thank you very much, Steve. Joanne, you'd like to come in, I think.
Yes, thank you, Chair. It is a question about innovation, and it relates, in a sense, more to the previous paper. It's about the way that 111 is interacting with the rest of the NHS. So I remember that when 111 was introduced, one of its real advantages was going to be that because the technology that underpinned it and the software that underpinned it was kind of homegrown within the NHS, that GPs would trust it enough to allow 111 people who worked in 111 to book patients in directly for appointments to their GP. So in other words, if somebody rang up 111 and 111 decided they needed to see a GP face to face, the patient didn't have to start again with their GP, but 111 could book them straight in. Now that we're using 111 in this sort of new, innovative way as a front door to urgent care, what I wanted to ask was, has that vision that was originally there for 111, has it been realised? And how successful have you been to persuade GPs that so GPs naturally feel that they know their patients best, and they're the best judges of whether the patient needs to be face to face. So, have we got to the point where 111 can book people directly into their GP, where 111 feels that they need to see a GP face to face?
So I think Pauline might have left.
I'm here.
Oh, you're there. Sorry, I just couldn't see you.
I think that's a really, really good question. And one of the things that I probably should have said in my report that I didn't, is that in developing 111 first, in each locality, in each area, it's fundamentally important that we work with general practice as well, and in the local messaging, and indeed in our regional and national messaging, that what we are actually saying to people is, look, if you have these types of issues, please contact your GP first. It is only if you have an urgent need, that means that you cannot wait until you can next see your GP, that you really should be contacting 111 or going online. But I think in answer to the question about where we can book patients from 111, yes, we can book patients in to some of our GP slots, and that's been very successful. And now we will be able to book patients in to our emergency departments as well.
Good, thank you. Thank you very much, Pauline. Well,
so one of the things that's happened through this process of the pandemic is, as you say, there's lots of innovation coming through, but the way the paper's written, so it sort of seems as if it's all come from the NHS itself, when in fact it's probably been more of a collaboration with the private sector and involvement with the private sector. And I'm sure some of the hundreds, and I think maybe even thousands of responses you've got will involve collaboration with the private sector. The impression the NHS has given in the past years as being a very difficult monolithic place to introduce innovation into, and yet we've shown we can be very porous, if you like. How do we make sure we capture that and encourage that going forward?
Well, I think you're right, Will, and of course, innovation comes from many places, and it won't just be the private sector. Of course, innovation has come from other parts of the wider health and social care system. So clearly, National Institutes of Health Research and research partners have worked very closely on and have driven with us the recruitment of people into trials. So I wouldn't want to, I certainly want to ensure that we recognise that it's not just the NHS that has driven innovation. I think on the question as to how we capture that and ensure that going forward we don't lose the momentum. I think Amanda talked a little bit to that earlier, and we have set our regions challenges to do that, and each region is working on a set of specific innovation challenges going forward. We have our academic health science networks already there, and one of the things that they do is drive innovation. And only this morning, Hugh's team was leading a workshop with our AHSNs on exactly this topic. So I think it's both a combination of ensuring that we are using those structures, those partnerships, those processes we've already got to drive innovation, but driving harder and faster. And no doubt capturing, actually through the innovations programme, new ways of innovating and new ways of going forward.
Yeah, well, I think it's the critical question, actually. How do we ensure that the NHS remains as open to innovation and accelerates the adoption of the innovation as we go forward? It's absolutely crucial. So a really big question, I think. So thank you for that. We're now moving on to the situation at Shrewsbury and Telford. And Dido, are you there, Dido?
Yes, I'm here.
Dido, over to you, please.
Right, of course, David. So I think the first thing to say is that we'd ask the board to take note of the update in the papers on Shrewsbury and Telford Hospital, specifically both the independent maternity review and the wider action that's being taken by the CQC and NHS Improvement in response to quite a range of quality concerns. And I chaired a board to system review meeting on Friday, attended by Amanda, Aidan Fowler, our patient safety director, Julian Kelly, our chief financial officer, Ruth Dale, Bywater, the regional director, and then a number of leaders from the trust, from the board, and from the local system. And I think we all came away from that meeting very concerned about the issues there and the need really to take quite significant action, both locally in the individual organisation, in the trust, across the system, and also for us as NHS Improvement to make sure that we are providing both the right support and the right challenge to address, as I say, the really quite significant issues. And I wonder whether, Amanda, you would just like to comment first and then hand over to Steve to comment on the Ockenden review specifically.
Yes, Dido, thank you very much. So I think the first thing to say, and I know I speak for all my colleagues when I say this, is that I think we would want to start by offering sincere sympathies to all family members, patients who've been affected by any failures in care at the Trust. Shrewsbury and Telford, as colleagues know, has been challenged for some period of time. This is not an organisation where this is a new set of concerns. But clearly, when I received a letter from Ted Baker, who's the Chief Inspector of Hospitals, from the CQC, outlining some really quite significant concerns recently, we took the opportunity not just to meet with him, but also, as Dido says, to institute this, which is a regulatory step in actually having a formal board to system review meeting, which happened at the end of last week. I think what I heard in the meeting was a real clear sense from the system leaders, because it wasn't just the Trust, it was, as Dido says, it was the region, but it was also members from the STP, from neighbouring organisations, that there was a recognition that actually it needed everybody to work together if they were going to play their part in supporting improvements in care at the Trust and for the population served by the Trust. So what we have done already is deployed an improvement team of unprecedented scale to support the organisation. We've not done that previously as NHS Improvement. It's been a single individual or sometimes a small group. So this is a much more comprehensive improvement offer. We've done that and are in the process of doing that at the moment, and that's to work alongside the staff in the organisation, really to strengthen the pace in which they can address the failings in care that have been identified. At the meeting, I think I also felt that it was very clear that the new chief executive, and she has only been in post for a relatively short period of time, that it was clear that she was very open in asking for support, that she was working closely with regional and national colleagues to identify what further assistance was required. And it was also clear that she was actively engaging with staff to ensure that they were clear what was expected and what support was available. Equally, I think I would agree with Dido, absolutely, and other colleagues may want to come in. I think we came away very clear about the scale of the challenge, and no one individual will ever be able to deliver the sustained improvements that an organisation such as Shrewsbury and Telford require. So the challenge for us, working, I think, very closely with the regional team and with the Trust and with the local system partners, is to think now about what additional support over above that improvement team I've talked about we can agree to put in place around that organisation to support them to be able to move at pace. So we are exploring strategic solutions to put in some of that additional support. And I should say that the chief executive of the Trust is fully supportive of that approach, and working with the region to identify those specific areas where another Trust, in particular a partnership with another organisation, would help them to accelerate the improvements that they need to make. We are continuing to work very closely with the CQC. We recognise that they play a very important role in ensuring that organisation delivers safe, high quality care. And I think, David, just to end really by saying I would certainly want to use this opportunity to confirm our clear and unambiguous commitment to enabling the organisation and system to address the issues identified by the CQC, and critically to gain the confidence of the local population and those who use their services, that they are receiving the standards of care that they can and should expect of the NHS.
Amanda, thank you. Could we go to Steve to give us an update on the Ockenden review?
Yes, thank you, Dido. And of course, I would want to echo Amanda's words and offer my heartfelt sympathy to all those families who've suffered as a result of poor maternity care, and of course to publicly state my thanks to all of them and others who continue to strive for improvements in maternity services. So as the board is aware, an independent review chaired by midwife Donna Ockenden was established in 2017 at the request of the then Secretary of State for Health and Social Care to investigate the handling of 23 cases relating to perinatal and maternal deaths at the Trust. And the board is also aware that since then, further families have come forward to that review and to the Trust, and that the Trust has indeed identified other cases of potential concern within its own records. And as of last week, the review has therefore widened its scope over time and is now considering 1,862 cases to see if they are the result of poor care. And this will be done in accordance with the updated terms of reference that were published in November 2019. Donna has now indicated, she indicated last week, that the review is now closed to further families coming forward so that she can complete the work that is needed to be done in the review. But the Trust will be able to deal with any remaining families who come forward with concerns, and they can be signposted to the Trust. But the task for Donna is now to complete the review, and ministers have asked her to complete a report by the end of this year. I won't go into the other details in the paper, but they do update the board on a recently launched police investigation and also on the publication by ourselves, NHS Improvement, of a report of investigation that we launched following a complaint into the Trust's handling of a report they'd commissioned from the Royal College of Obstetricians and Gynecologists in 2017. So I'll leave it there and hand back to you, Dido.
Thank you, Steve. Ruth, is there anything that you would like to add?
Thank you very much, Chair. So in line with Amanda and what Steve's done, it's deeply distressing what these families have had to go through, and I recognise that and extend my sympathies alongside my colleagues. I guess I'm more disappointed in the most recent CQC inspections around the fundamentals of care that have been described as not being there, particularly around falls prevention and pressure ulcer care, both of which are fundamentals of care. The Trust does have more vacancies than a national average. So we've got, clearly the Trust has got more to do on that. And so I'll be working with Amanda and Steve and colleagues to further progress the strategic solutions along with yourself, Dido.
Thank you, Ruth. Unless there are any other comments, David, I think on behalf of the whole board, we should just formally note our deep sympathy and concern for all the families that have been affected, and sort of state our intention to do whatever it takes to support the Trust and the system to get back to the standards of care that I know that the staff working there want to be able to deliver, and we need to get there as fast as we possibly can.
Thanks very much, Dido. I think we'll definitely want an update again from the next board meeting.
Indeed.
Good. Well, thank you all very much. Is there any other business that anyone would like to raise? Would Laura Way-Geary, do you have anything you'd like to say at the end, or are you happy to bring it to an end? Okay. Dido, is there anything you wanted to just say at the end before we sign off?
No, I'm good. Thank you.
Okay, good. All right. Thank you all very much. Thank you.